that's a fundamental tension, is that you don't want to delay going to the OR for definitive care. At the same time, you don't want to immediately have a clean kill by not properly resuscitating your patient first.
If you do, I mean, the thing about non-invasive, as Rich said with those intubate and die situations, if you have a little bit of time and you have non-invasive, if you put a patient with, you want to intubate them, but you have a little time to set up, you put them on non-invasive and they have tamponade, you will see that same effect of positive pressure ventilation, but you're not committing to the procedure. So you get a sense of what is their blood pressure going to do once I intubate them if you have them on non-invasive. And if you get into trouble, you can always turn the non-invasive off briefly, and then, or you can have a sense of, okay, now I need to get my drugs mixed up. So that's a reasonable thing to do in patients that you have a little, I mean, you can't do that in someone who's crashing in front of you, but that's a reasonable thing to do if you have a little bit of time to kind of get ready for those large PEs or tamponade cases where you have to intubate them, but you don't have to do it right this minute. The other thing, as Dan was saying about the trauma patient too, so if you have someone who's bled out half their blood volume, their oxygen saturation is still 100%, right? They still, especially in a young healthy person who doesn't have lung pathology from their trauma, their sats are still 100% even if they have half their blood volume. The problem is they desaturate much quicker than they would if they have their full blood volume. So not only do the trauma patients tend to drop their blood pressure, but their sats tend to drop much quicker than the same patient who hasn't lost half their blood volume. So you have to be really aware of if you can transfuse them, if you can get a couple liters of O negative into these patients, you help with their blood pressure, but you also make your intubating conditions from the saturation standpoint much better as well. So that's a conflict that often trauma wants you tube, and if their sats are good and they're maintaining their airway at the moment, you have the time to transfuse a couple units of blood, and that will make your intubation much less likely to kill the patient. But you just kind of have to convince the trauma surgeons that that's a worthwhile thing to do.
And I think that what Dan and Rich are bringing up about using NIV, it's appropriately taught that you don't put people on NIV with low GCSs that are altered. And that's true with the proviso of if you're in the room ready to intubate, that's a totally different ball game. So, the statement of, look, if they're altered, you do not put them on NIV, full stop, is an oversimplification. Because if you're in the room ready, then you'll see the stuff that Dan's talking about. You'll see that their blood pressure's dropped or they can't handle it or they're at risk of aspiration. You'll be there to manage all of those risks that you simply cannot put them on NIV and then leave the room. This is you're in the room the entire time resuscitating.